All right. So welcome to the third presentation of Krok 2 2020 booklet, the third presentation. So let's not waste much time. Let's start right away. In a pediatric clinic located in a rural area, there are 9 children who simultaneously fell ill. So whatever it is, everybody's having it. The following signs were detected: low physical activity, acrocyanosis of the nasolabial triangle and the fingertips, mucosal cyanosis, tachycardia, dyspnea. It was determined that all the 6 children were fed with a formula. So it's some kind of food, isn't it? That was dissolved in the water taken from a dark well. Taken from a dark well. Now, laboratory analysis revealed high level of methemoglobin in the blood of the children. So this is where you'll be looking at the, of course, the history of the patient. But in the blood, we are having methemoglobin. Now, these signs can be caused by increased content of a certain element in the water. Name this element. So the question is that we want to look for the possible causes of methemoglobin. That is what it is. And a methemoglobin is simply a condition of elevated methemoglobin in the blood. That means too much of methemoglobin is inside the blood. Now, of course, we can talk about the shortness of breath, the dizziness, the poor coordination, the blue-colored eyes, whatever it is. You can mention all of these things. However, the substances that are involved include benzocaine, like benzene, benzocaine, nitrate, and dapsone. Again, the substances that are normally involved in methemoglobin intoxication include benzocaine, nitrate, and dapsone. So these are the possible, of course, there could be a lot, but these are some of the few substances that can lead to increased level of methemoglobin inside the blood. So therefore, from what we're having over here, what we can be looking at for is nitrate to be our element of discussion. So nitrate. A 20-year-old man suffers from headache, general condition, and face edema that appeared in the morning. So face edema appeared in the morning. 18 days earlier, he had a case of tonsillitis. Guys, before I continue, you already know your answer. This is definitely a case of what? Of course, this is a how do you call it? A kidney problem, isn't it? But this kidney problem is as a result of this tonsillitis. So you are thinking of what? Post-streptococcal glomerular nephritis. We've talked about this countless number of times. So please, if you are lost, do well to watch the previous videos. Good. Now, don't confuse all of these things with the mid slopes, which normally is commonly found in kidney stones or urolithiasis. It's commonly found there. But looking at the pathogenesis of everything over here, we will be looking at post-streptococcal glomerular nephritis. And so therefore, your answer here should be what? A, acute glomerulonephritis. But the real disease is post-streptococcal glomerular nephritis. So every other thing here is just confirming that. Edema formation, costovertebral angle tenderness is negative. Mid-slopes protein. And don't also forget the difference between nephrotic syndrome and nephritic syndrome. Nephrotic syndrome and nephritic syndrome. Look at that. Diuresis is 400. This is very low. So this is oliguria. All right, that's just by the way. So let's continue. You know this. Now, an 18-year-old patient always obeys others, always, and adapts to his needs to demand he adapts his needs to the demands of people on whom he depends. Charlie. He excessively defers to their wishes and makes them responsible for his well-being. Cannot defend his interests and needs support from other people. Such psychic profile has been formed in the childhood, remains unchanged, and hinders adaptation. Guys, this is just what a dependent personality disorder is. Just right in your question. Dependent personality disorder. A 35-year-old woman complains of a pain in her right axillary region. She has been suffering from this condition for a week. Her body temperature is 38. The axillary region, there are 2 formations, 2 centimeters in size each. Skin over the formation is dark red and thin. Palpation produces a yellowish white discharge from a fistula opening. What is the most likely diagnosis? What is the most likely diagnosis? And over here, we will be looking at hydradenitis. Hydradenitis. Not a furuncle or a carbuncle. These furuncle or carbuncle, now a furuncle is just a boil. A boil. Multiple boils are called carbuncle. So boils. But over here, this is not a boil. This is hydradenitis. Also called acne inversa. This is characterized by an occurrence of an inflamed and a swollen lump. It can be painful and can break open, releasing fluid or releasing what? A pus. And usually it affects under the arms, under the breast, and around the groin area. So please don't confuse these few stuff with furuncle, carbuncle, and stuff like that. Don't confuse them with it. So over here, we're looking at what? Hydradenitis. And even looking at the size. All right. Now, during a regular examination, an 8-year-old child with type 1 diabetes presents with a swelling on the anterior surface of her hip. Okay. The swelling is 3 centimeters in diameter, dense, painless on palpation. The skin over this formation has normal color and temperature. Localization of the swelling. Guys, this is where you need to pay attention to. The localization of the swelling matches the place where the girl usually receives her insulin injection. So guys, what are you looking out for? What are you looking out for? Of course, over here, this is because of what? The injection, isn't it? So we could be looking at what we call injection site swelling. So this is what? Injection site swelling. Injection site swelling. Technically, we call it lipohypertrophy. Lipohypertrophy or lipohypertrophy. That is the technical name for injection site swelling. And this can occur when insulin is injected into one site repeatedly. All right. So that is what we are looking at over here. And usually they are of fat. They are like a fatty lumps. And because they are fatty lumps, they do not normally have a supply of nerves and blood vessels and stuff. That is why they are not red or they are not what? Painful. So it is what? Kind of painless, but it is swelling. It is swollen, but it is painless. It is not red in color. Usually it will happen so when the place is being supplied with nerves and is being supplied with blood. But there's nothing like that. So over here, we are having what we call what? Development of a hypertrophic lipodystrophy. It's the same thing. Don't confuse it with post-injection abscess. There's no abscess formation over here. There's no abscess. This injection site swelling. All right. A 52-year-old woman has been suffering for 2 years from a dull, occasionally exacerbating pain in her right subcostal area. If I were you, I'll put my hand on the right subcostal area. Yes, your right side. Occurring after eating high-fat food. Guys, even without going further, we've talked about this. You are definitely thinking about what? The gallbladder. You are thinking about the gallbladder. And we said if you're thinking about something like this, there are some examinations you need to do. And one of them that you will do is what? Your ultrasound. Regardless, you must always do what? Your ultrasound. Your ultrasound. Now, if you might be thinking of cholecystography as a possible examination to do, which of course is good, but cholecystography is used specifically or especially to detect the presence of stones or what we call gallstones or stones in the gallbladder. All right, so basically everything here is talking about what examination will be most useful. And of course, we're looking at ultrasound. Every other thing here is telling us that there's a problem with the bowel release. So here we have what? A to be our answer. Ultrasound. All right. A family doctor performed an external obstetrical examination of a pregnant woman and determined that her uterine fundus is located at the level of the navel. What is the most likely term of pregnancy? Now, I believe when we did it with obs and gynae, you realize sometimes they were saying the fundal height is this, fundal height is this, fundal height is that, or it's above the umbilicus, it's 22 above this, it's 23 above that. Yes, it is used to check the gestational age. So now let's look at it. So usually about 3 months of pregnancy, that is 13 to 14 weeks of pregnancy, the top of the uterus is usually just above the mother's pubic bone, just above it. So in 3 months, your baby, 3 months simply means 13 to 14 weeks. The fundus or the uterus, the top of the uterus is just above the mother's pubic bone. Good. At about 5 months, that's about 20 to 22 weeks, the top of the uterus is usually right at the mother's belly button. So that's the navel. 20 to 22 weeks is around the navel or the umbilicus. That's where it is. So over here, even though there's no 20 or 22, looking at the option that we have over here, 24 will be the ideal gestational age, the ideal term of pregnancy. So therefore, over here, your answer or our answer should be 24 weeks. But of course, if you want the exact, that should be what, around 20 to 22. All right. What should be prescribed as secondary prevention drugs for patients with atrial fibrillation after an ischemic stroke caused by cardiac embolism? So one of the things that AFib can cause is that it can lead to what? Coagulation. It can lead to what? Coagulation or clotting. That is why we always give anticoagulant for patients that are suffering from AFib or even having myocardial infarction. Because if you have myocardial infarction, you can easily develop AFib as well, isn't it? So we normally give them anticoagulant to prevent clotting or to prevent coagulation. However, so now then the question is that now assuming the patient was not given that, it means that clotting can be formed. And when clotting is formed, those clots can break and, of course, go and cause problem. That's what we're having with the cardiac embolism. That can lead to what? To stroke, because it could block a major blood vessel supply to the brain, and that can lead to what? To stroke. So over here, of course, we have to give what? Anticoagulant. So here, your answer should be a oral anticoagulant. All right. A 55-year-old woman complains of thyroid gland enlargement. That can be observed throughout the last 2 years in the discomfort during swallowing. Objectively, she has signs of hypothyroidism. Okay. The thyroid gland is, on palpation, is dense, non-fused, with surrounding tissues and mobile on swallowing. Regional lymph nodes are not enlarged. Guys, look at this. In the serum, there are anti-thyroid antibodies. So that means that the thyroid is fighting against itself. And that term is called what? Or that disease is called what? Hashimoto thyroiditis. Whereby the body immune system begins to attack itself. So over here, we are definitely looking at what? Hashimoto thyroiditis. So your answer is D. A 12-year-old girl, after a case of a respiratory infection, normally caused by virus, isn't it? Yeah, developed a dyspnea at rest, paleness of the skin, and heart rate is 110, BP is 90/55, heart sounds are muffled, borders of relative heart dullness. We have the right. On the right, we have the parasternal line. The upper, we have the third rib. The left, we have 1 centimeter outward from the midclavicular line. Make your provisional diagnosis. So over here, we could be definitely looking at a problem with what? Infection of the myocardium as a result of the respiratory infection. So this is actually a complication of respiratory tract infections. And why we are saying this is myocarditis is because myocarditis is normally, yes, it can be caused by bacteria, but usually caused by a virus, or it is of a viral infection or viral origin. That's why over here, we will go in for infectious myocarditis as our answer. Myocarditis. This is an inflammatory cardiomyopathy. Again, what am I saying? Because of the history of the respiratory infection, which could be of a viral origin, we could be thinking of myocarditis or inflammation of the heart muscles. Myocarditis. That's leading to all of these things being present. So therefore, we'll be thinking of what? Myocarditis. So your answer here should be what? Should be C. Now, there's something I need to know, that on the ECG, we can have a diffuse T-wave inversion. Saddle-shaped ST segment elevation may also be present, but that can also be seen in pericarditis. But over here, even though they didn't bring anything relating to the ECG findings, we could also add this at the back, or put this at the back of our minds, that if they have brought diffuse T-wave inversions and things like, or saddle-shaped ST segment elevation, we could still be looking out for what? Myocarditis. But like I said, with the saddle-shaped ST segment elevation, it may also be present in pericarditis. All right. So what your answer is C. A 19-year-old young man complains of cough with expectoration of a purulent sputum. Guys, 100 mL per day. Hemoptysis, we've done this. Hemoptysis, dyspnea, increased body temperature. For those who don't know what hemoptysis is, coughing up blood. General weakness, weight loss. Condition lasts for 4 years. Exacerbation occurs every 2 to 3 times a year. Patient presents with malnutrition, pale skin, cyanosis of the limbs, clapped fingers, tympanic. Now, don't forget, when we talk about clapped fingers, We are talking about hypoxia formation, because when there's hypoxia, of course, that can ensue. And again, cyanosis is there, telling you that there's not enough oxygen. Now, tympanic percussion sound in the lungs, weakened respiration, numerous various moist crackles in the lower pulmonary segment on the left side can be observed. Guys, erythrocyte, leukocyte, ECR on examination, on X-ray, the lung fields are ephysematous. The left pulmonary root is deformed and dilated, guys. It is ephysematous. The root is deformed and dilated. What are we looking out for? So now the clue here to help us is the fact that we're having a deformed and a dilated left pulmonary root, which makes bronchiectasis the likely diagnosis. Bronchiectasis. And this is just a disease where there's a permanent enlargement of the part of the airways of the lungs. Permanently enlargement. Okay, so this book can have a chronic cough with mucus production. They can have shortness of breath. They can cough out blood. That's hemoptysis. They can have chest pain, wheezing, drumsticks, and all of this. They can all what? Okay, and they are prone to lung infections. They are prone to lung infection. So having all of these things being present with a sputum of 1,000 mL per day, guy, we're definitely looking out for it. For bronchiectasis of the left lung. So multiple bronchiectasis. All right. Again, you can find all these explanations on medentweb.com. Medentweb.com. So do well to log onto that website. All right. A patient 1 year old had a Q wave myocardial infarction on the posterior wall of the left ventricle. For the last 2 weeks, he has been suffering from daily attacks of AFib and bradycardia, accompanied by both of vertigo. What tactics is the most advisable in this case? What is advisable in this case? So over here, the conducting system is having a problem, isn't it? The conducting system might be having what? A problem, which would be an indication. And look at it. We're having what? So the attacks of the AFib, the bradycardia episodes, these are all indications that the heart, whatever that is firing, is not firing enough. There's not enough fire. There's not enough impulses for contraction to take place. Do you get me? So that is what we are looking out for. And if it is that, then this is simply an indication for a pacemaker implantation. It's an indication for a pacemaker implantation. And that's why over here we are going for B. Why? Because there's what? A damage to the body's intrinsic conduction system to produce impulses. There's a problem. So we need to give this artificial pacemaker, or we need to put an artificial pacemaker over there. So over here, your answer is B. A 58-year-old woman has type 2 diabetes that is compensated with diet and metformin. Like you can see metformin. Why we say type 2, you give metformin. Exactly. Now she prepares for cholecystectomy. Okay. That means you want to move the gallbladder. Okay. Her height is 164, weight is 90, heart rate is 72, blood pressure is that, her abdomen is soft, painful on the right subcostal region. Liver is not enlarged, fasting glucose is 6.2, glycated hemoglobin is 6.5. Again, it's not supposed to be more than 6. So 6.5 means indeed there's diabetes. What further tactics of sugar lowering therapy should be chosen in this case? Sugar lowering therapy should be chosen in this case. Yes, this is what type 2. And again, I ask you guys to go and look for the difference between type 1 and type 2. But usually, these people is scattered by too much of what? Sugar, insulin, resistance, and the relatively lack of what? Insulin as well. These are the people that having what? Type 2, and it can be prevented through proper nutrition, like in this case, and of course, regular exercises. But there's no exercise over here. So, but now, the reason why they are asking us this question is because we are preparing this patient for a surgery. We are preparing this patient for a surgery, And because of the presence of diabetes, there is an increased risk of mortality. That means increased risk of death or cardiovascular event and even renal failure. These things are prone to happen when the person is having what? A disease like diabetes type 2, about to go for what? Surgery. So over here, we're looking at what? A prophylaxis for the patient that can help the patient undergo this surgery successfully. So to do that, we have to give a short-acting insulin. Short-acting insulin. That's what we need to do to help this patient go through this surgery successfully. And that's over here. Our answer would be A. Short-acting insulin. Short-acting insulin. Although these people are also what? Insulin resistance. All right. So short-acting what? Insulin. Okay. This is just a prophylaxis. But for treatment, that's it. Metformin, diet, and exercise. A 23-year-old woman came to a gynecological clinic. She complains of pain, itching, and burning in her vulva, general weakness, indisposition, elevated body temperature, headache. The vulva, there are multiple vesicles up to 2 to 3 millimeters in diameter with clear content against the background of hyperemia and mucosal edema. Guys, having sores, multiple vesicles, that's like sores, having sores of 2 to 3 centimeters in diameter. Guys, what are you looking at for? Definitely, you are thinking of what? Herpes infection. Herpes infection. So this is what? A genital herpes infection. Genital herpes infection. Don't forget, we have type 1, type 2. In type 1, type 1 can cause the genital herpes, but most cases of genital herpes are caused by type 2. Type 2. So in Krok, if they to bring what type of herpes infection is it? This is what? Type 2. All right. A 5-year-old child had acute onset of the disease that manifested in the body, that manifested in body temperature up to 39. Marked chills, weakness, inertness, skin pallor, headaches. 8 hours later, a hemorrhagic rash developed on the skin of the buttocks and the legs. Hemorrhagic rash. The child is sluggish, temperature has dropped, blood pressure is now 80 to 40, respiration is 28 to 30, diuresis is decreased, that means urination is decreased. Make your provisional diagnosis. Now, you can tell that shock is developing. So with the presence of shock or low blood pressure, we can easily rule out hemorrhagic vasculitis or Hinox purpura. Because I know some of you might be thinking about Hinox purpura, but this is not Hinox purpura. Just one reason is because I told you guys that with the hemorrhagic vasculitis, normally it can affect the bottom. In fact, They love the buttocks and then the legs a lot. But this is not it. Why? Because of the drop in the blood pressure. So you can easily rule that one out. Therefore, we are left with what? Meningococcemia to be the likely diagnosis in this case. Meningococcemia. So here, your answer should be what? Should be C. Meningococcemia. That should be our answer. All right. A 43-year-old man complains of a facial edema, dyspnea, and difficult swallowing that appeared 3 hours after he was stung by an insect. So again, this is definitely an allergic reaction. So objectively, the skin of his eyelids, cheeks, and the lips are hyperemic and edematous. Guys, the question is, what do you give for somebody suffering from allergic reaction such as this? All right. So normally, now this is the protocol. Okay, this is the protocol. Anytime you have an allergic reaction, look at what is happening. Otherwise, you might confuse because we have histamine there, we have glucocorticoids there. In some questions, you might even have adrenaline there or epinephrine there. So what do you do? Now, take it from me. So anytime we are having a case like this, and then we have, just take your time and then listen to me very well. Now, when you have an anaphylactic attack, when we talk about anaphylactic attack, don't forget, anaphylactic attack, there will be cardiovascular compromise in anaphylactic attack. Cardiovascular compromise. That means there can be shock developing in the patient. So in that case, what you have to do is we can do CPR, you can do resuscitation with epinephrine or the adrenaline. Okay, especially when you have cardiovascular compromise, breathing is impaired. I mean, shock is developing everything. Please and please again, the first line of treatment will be what? To give your epinephrine or to give what? Adrenaline. That will help to stabilize the person. After stabilizing the person, you want to give the person what? Oxygen to help the person to breathe. Oxygen to help the person to breathe. After giving oxygen, you give IV corticosteroids. Corticosteroids to reduce the inflammatory reaction that is taking place and to also to improve what? Breathing. Then you can now give your antihistamine to reduce the itching. So antihistamine is used to reduce what? Itching. To reduce itching. But let's look at the question over here. Now we are having what? Facial edema, dyspnea, difficulty swallowing because of what? A bee stung. Eyelids, they are just hyperemic and edematous. So this means that there is an inflammatory reaction. There is an inflammatory reaction. This is not about itching. There is not a cardiovascular compromise. There's no cardiovascular compromise over here for you to give adrenaline. No. And there's no itching whatsoever here for you to start thinking of perhaps antihistamine. No. So over here, what should come to your mind first is what? To reduce the inflammatory process. And so therefore, you give your corticosteroids. So over here, we will prescribe corticosteroid as a first line, or the first thing we will do, corticosteroids. So please don't confuse them. All right. When planning treatment of a patient, it was decided to use a medicine with evidence level A. Okay. What trials produce the evidence that allows to classify the medicine as level A? So we need to know what levels of evidence are all about. So now levels of evidence, sometimes we call it hierarchy of evidence. These are assigned to studies based on the methodological quality of their design, methodological quality of their design, the validity and applicability to a patient care. That is what level of evidence is all about. So it's more or less ascertaining that something is of high quality, something can be used for the patient, something is, you can use that thing to cure that particular disease. Basically, that's just it. But now there are different types, or there are different levels according to the purpose that you want to achieve. There are different levels depending on the purpose that you want to achieve. Now, in level A, or evidence level A, this is from a systematic review of all relevant randomized controlled trials. Relevant randomized controlled trials or evidence-based clinical practice based on a systematic review. Based on a systematic review. So that is what the evidence A basically deals with. And it is of good quality. Very, very good quality. That's evidence A. So again, evidence A is from what? You have done several systematic reviews, a lot of randomized controlled trials and stuff to ascertain that yes, this is good for this purpose or to treat this patient. That is what evidence A is all about. And that's why over here, we will be going for what? For data that is obtained from several randomized clinical trials. Several of them, but relevant ones. Several but relevant, or evidence-based clinical practices. That is what it is all about. Now, in type 2, or in evidence B, this is obtained from at least one well-designed randomized controlled trial. Just at least one. That is for what? Evidence B. Evidence C is obtained from a well-designed controlled trials without randomization. Without randomization. Take note. Evidence D is from a well-designed case control or a cohort studies. Remember, I talked about cohorts in our previous presentation. So please go back and then watch it and then understand it and then apply it over here. Good. So evidence D is from a well-designed case control or a cohort studies. Good. So in Krok, maybe in 2021, they might not bring evidence A. Maybe they might bring evidence B. Evidence C, evidence D. Please don't be lost. Don't be lost. All right. Good. So over here, we are looking at what? At A as our answer. A as our answer. After the pregnant woman's waters broke, it was noted that they are significantly contaminated. They are contaminated with Meconium. Okay. Upon birth, the baby is not breathing. Remains inert. The skin is cyanotic and covered in Meconium. Definitely, the person might have taken in this or might have aspirated. Now, what resuscitation measures should be taken after the baby is born? After the baby is born. So definitely, we are having a case of Meconium aspiration syndrome. Meconium aspiration syndrome, which refers to the breathing problems that a newborn baby may have when there are no other causes and the baby has passed Meconium. Sorry, Meconium. Meconium. Meconium simply means stool. So please don't just get confused. It's a stool. When the baby has passed Meconium into the amniotic fluid during labor or during delivery. During delivery. So what do we do for, such a case? Now, if you look at the question over here, this baby is actually in a respiratory distress. The baby is in respiratory distress. And to manage this person, we just need to intubate the baby and visualize whatever that is there. And of course, allow breathing to take place. Allow breathing to take place. And that's what we'll be doing. So over here, we will do what? Of course, we can do but I think the first thing for us to do is to first of all, maybe intubate so that the person can breathe. Because the person cannot breathe and you're going to do laryngoscopy. I don't know. But first of all, we have to sustain, we have to stabilize the airway before you start thinking of looking at the cause, isn't it? So stabilizing the airway, we would need to do what? An intubation. Definitely, we would need to do an intubation. Then we can now look at what? A laryngoscopy, or we can use a laryngoscopy to check for the possible, perhaps, cause, and of course, things like that. So basically over here, your answer is what? Is C. Is C. For me, I'll do the intubation first before doing the laryngoscopy. But I don't know. I stand to be corrected. So please feel free to share your thoughts on this as well. So the laryngoscopy come before the intubation, or intubation should come before laryngoscopy. So I'll leave it to you guys. But regardless, your answer will still be correct. All right, so your answer is C. A 5-year-old child has been ill for 2 weeks. Cough attacks developed first and were then followed by represses. During coughing, the child's face turns red and cervical veins bulge. Then this cough is very, very, very severe. Cough attacks induce vomiting. Interesting. X-ray shows intensified bronchial pattern. Leukocyte is 16. Lymphocyte is 72. Erythrocyte immunization rate is 4. What is the likely diagnosis? Ladies and gentlemen, we could be looking at a whooping cough. A whooping cough. A whooping cough. So coughing for 2 weeks, Charlie, it's not easy. It's not easy. All right, so over here, we could look at what? Pertussis, because whooping cough is caused by what? Pertussis. 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 Bordetella. Pertussis. Bordetella. All right. Good. So, yeah, A should be our answer. A 48-year-old woman has arrived to the surgical unit with wounds in her thigh. On examination, the wound surface has dark gray coating with unpleasant sweet smell. Sweet smell. Dirty gray coating. Unpleasant sweet smell. Wound content resembles raspberry jelly. You already know what it is. Of course, you're thinking about Clostridium, isn't it? Now, the skin tissues around the wounds are glossy and turgid. Palpation revealed moderate crepitation in the tissues. What microflora? Guys, you are definitely looking at a case of what? Tetanus. Or we're looking at what? Anaerobic Clostridium. That's the causative agent. Anaerobic Clostridium or Clostridia. Clostridia. This is a deep wound. Okay. And now there is necrosis forming and things like that. You know, these things normally is because of what? Clostridium. Clostridium. All right. So the answer is D. Anaerobic. Anaerobic. That means they dwell well in the low oxygen environment. All right. A patient underwent suture application. Suture application of the perforated duodenal ulcer. On the 3rd day after the operation, he started producing a large amount of discharge from the abdominal drain tube. The discharge contains bile and high amylase levels. What complication occurred? Guys, don't confuse the discharge. Think about what went on. A patient underwent suture. Suturing. Okay? So there was what? A suturing. Then after the suturing, 3 days later, we're having all of these things. So this means that there could be an incompetent suture taking place, or the suture was not done properly. Suture was not done properly. Because if it was, perhaps we wouldn't have seen all this discharge coming out from the person. So over here, we will definitely look at what? At a suture incompetence of the ulcerative defect, that's the duodenal ulcer. There was a suture incompetence. Suture incompetence. All right. A 40-year-old victim of a traffic accident sustained the following injuries: closed diaphyseal femur fracture, brain concussion, multiple rib fracture, pneumothorax, degloving shin injuries. What injuries require the most urgent? Guys, most urgent. You are thinking of your lungs, guys. You are thinking of your lungs. Very, 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 very important. Anytime there is a road traffic accident, what we are looking at for, the lungs, the heart, the brain are intact. The lungs, the heart, and the brain are intact. These are the first thing we look at. Very good. So, looking at that, now let's look at it. With all these things taking place, which one of them should we attend to first? And of course, the rib fractures and the pneumothorax. That should be the major thing we need to be looking at for. Rib fracture and the pneumothorax. Okay. Because the lungs before the heart, then perhaps we can think of the brain. They are all important, but first of all, we have to make sure your lungs are making you breathe. Because without oxygen, trust me, you'll be dead in no time. So D will be our answer. D. A 20-year-old woman, gravida 2, para 1, has been in the labor for 4 hours. Her condition is satisfactory. Moderately painful contraction occur every 3 minutes and lasts. Okay. The waters have not burst yet. The fetus is longitudinal position. Fetal heartbeat clear and rhythmic. Major segment of the fetal head is engaged. Okay. Vaginal examination shows smooth cervix up to 6. Guys, so definitely, this is 6 centimeters. So this is definitely in the active phase of labor. This person is in the active phase of labor. So the opening, at least, is more than 4 centimeters. More than 4 centimeters. So over here, we are looking at active phase of labor. Active phase of labor. So your answer should be B. Active phase of, and of course, the labor is normal. Labor is normal. Everything is normal. All right. Again, do well to check on medentweb.com where you can practice all these questions. They come with explanations. Okay? I know you are using the e-neutron, the test Krok center. They are all good. But you need to understand why the answers are so, isn't it? Yeah. So after watching this to get the whole idea of what I'm trying to say, you go there and you solve and you get to know why again. So it's a very good platform for your revision. All right. A 22-day-old infant developed subcutaneous red nodes from 1 to 1.5 in size on the scalp. Later, the nodes suppurated. Temperature increased. Intoxication symptoms appeared. Regional lymph nodes enlarged. Complete blood count. There's anemia, leukocytosis, neutrocytosis, increased ESR. What are you looking out for? What are you looking out for? Over here, we are definitely, don't forget, subcutaneous red nodes. Subcutaneous red nodes on the scalp. This doesn't mean that this is a scalp phlegmon. No. This is pseudofurunculosis. And a pseudofurunculosis is simply an infection of the hair follicle leading to abscess formation with accumulation of pus and necrotic tissues. And usually it is formed on the scalp. Usually it is formed on the scalp. A phlegmon will be spreading. Yes, abscess, but it will be spreading all over. To be spreading all over. That's what a phlegmon. Okay. Good. So over here, definitely we're looking at what a pseudo furunculosis infection of the hair follicles. Infection of the hair follicle. All right. Good. 26-year-old man complains of chills, rhinitis, dry cough, fever. Examination shows him to be in a moderately severe condition. Small pale pink non-matching spots on the skin of his back, non-matching. Abdomen and extremities. Palpation revealed enlarged occipital and axillary lymph nodes. No information about vaccination history could be obtained. Guys, you are definitely looking out for what? The German measles. German measles. So over here, German measles means what? Rubella. So this is a rubella or the German measles. Good. All right. So the answer is what? Is C, rubella. So there no history of vaccination. 38-year-old patient has been brought by an ambulance to the surgical department with complaints of general weakness, indisposition, black stool. On examination, the patient is pale. There is dotted hemorrhages on the skin of his torso and extremities. On digital examination investigation, there are black feces on the gloves. Hemoglobin is 108. And there is thrombocytopenia. They've told you there is what? Thrombocytopenia. Analysis states that a similar condition was observed 1 year ago. Make your diagnosis. No, I think the options here are, okay, yeah. Make your diagnosis. So, definitely, with the history of thrombocytopenia being present, they've literally told you the answer. So this is definitely what? A thrombocytopenic purpura. Thrombocytopenic purpura. No, this is not hemophilia. This is thrombocytopenic purpura. This is C. Not hemophilia. This is C. Hemophilia will be dealing with clotting factors, but this is not a clotting factor problem. This is platelet issue. Platelet issue. And it seems the blood is even normal because hemoglobin is 108, even though it is not up to 120, but it's considered okay. So anytime we are having a blood analysis to be normal, with the exception of thrombocyte or platelet, then we could be looking out for what? Thrombocytopenic purpura as the possible diagnosis. All right, so here is C, not B, C. The body of a citizen was found at the place of his dwelling. On his face, neck, and hands, there were detected irregular shaped wounds, varying from this to that. The skin and underlying tissues are absent in the wounds. The margin of the wounds are uneven, with major and minor scalloping along the edges and no signs of bleeding. What is the initiating mechanism of these wounds? Guys, there might not be no bleeding. There might be absence of bleeding, but this is definitely a bite wound. Because, just look at the how your teeth will be like, irregular shape. So even think of it that way to help you with your answers. Over here, we are looking at what? An animal bite wounds. Animal bite wounds. With the stabbing, there can be blood. Now with biting, there might not be blood. It's possible there may not be blood. Just look at how many times the people that you are biting, those days when you're fighting, when your strength cannot help you, you have to get a lawyer from your teeth to bite. All right. In those days, in Ghana, they will go and put chicken, the feces. They will go and take it and put it on the place of, where you the site of biting. They will put it there so that your teeth will become rotten. Very funny. I don't even know what they believe we're thinking of. I don't know. Oh Lord, help us. So this is D. This is D. All right. Please, if you didn't go to that stage of your that stage in your lifetime, it means you are Indomie baby. You are just an Indomie baby. So don't talk plenty, Indomie baby. You understand. All right. What do we have here? A multigravida, labor 2, 36 to 37 weeks of gestation, has gone into labor. Her water broke 8 hours ago. 8 hours ago. Labor activity continues for the last 4 hours. It is regular with contraction that lasts 35 seconds and occur every 3 to 4 minutes. The child is in a cephalic presentation with the head pressed to the entrance into the lesser pelvis. Parturient woman complains of sudden sharp abdominal pain. Her pulse is 100 per minute. Blood pressure is 110. I think blood pressure has moved from 110 to 72, 100 to 70. The uterus is tense and does not, look at it, the uterus is tense and does not relax between the contraction. Fetal heartbeat is muffled with 100 per minute. The amniotic fluid is blood-colored and continues to leak. What is the most likely diagnosis? What is the most likely diagnosis? Well, I don't know for Krok, but this could have been an umbilical vessel problem. An umbilical vessel, rupture of the umbilical vessels. This could have been rupture of the umbilical vessels because of the amniotic fluid coming up with the blood, and that is continuing to leak and stuff like that. However, Krok said this is placenta abruption, that is premature detachment. Now, why I disagree, of course, feel free to share your opinion as well. We are learning, so feel free to share your opinion. Now, why I disagree is that in a premature detachment of the placenta from the normal position, usually the heartbeat of the baby might not even be heard. Might not be heard, isn't it? Might not be heard. Might not be heard. So that's my argument. That is my argument. Or the baby could be in distress. The baby could be in distress, which may be why they chose premature detachment, could be because of that. Because over here is 100. And I think it's supposed to be about around 110 to about 160 to 160. So having 100, it means maybe this person is, the baby is in distress, which could make this a possible answer. So for me, that is where I am thinking about why they chose placenta abruption as the likely, the likely answer. That's what I'm thinking, why they chose it. But like I said, for me, I was thinking of this as a rupture of the umbilical vessel. When I first saw it, I was thinking of the umbilical vessels being ruptured because of the fact that there are blood and it is leaking and things like that. That means there's bleeding somewhere. That's the whole point. There's bleeding somewhere. And that bleeding could only come out from the vessels, isn't it? That's what I'm thinking about. That was what I was thinking about. But like I said, I stand to be corrected again. And the reason why maybe they chose the placenta abruption is because of the reduced respiration of the baby. The reduced heartbeat of the baby, rather. All right. So over here, your answer here is D. Your answer here is D. Your answer here is D. All right. Good. A 45-year-old woman complains of increasing body weight throughout the last year. Examination revealed moon face syndrome. Some of you started thinking of Cushing. This, yeah, I know, right? Brittle hair, hirsutism, stretch marks, disproportionately thin limbs. Patient height is that, weight is that. What type of obesity is it? Like I said, many of you are thinking about Cushing and stuff like that, which of course is not far from right. You could be, in fact, you're correct. Me, I was talking about Cushing, and I'm thinking about so this actually what a type of obesity called abdominal obesity as well, or a central obesity, because it's happening on the, you see, the abdomen, stuff like that. So central. So we could think about central obesity, abdominal obesity, or even Cushing syndrome or Cushing disease. That could have come to your mind. However, in the absence of these things we are all mentioning, we could be looking at dysplastic obesity. Dysplastic obesity. And this is the term that is used to describe the presence of abnormal cells within a tissue or organ. The presence of abnormal cells within a tissue or organ. Now, dysplasia is not a cancer, but it may sometimes become a cancer, isn't it? And in a way that I'm also thinking about it is this. Cushing disease is normally as a result of perhaps a cancer in the pituitary gland, isn't it? So maybe, just maybe, we can connect the dysplastic to the Cushing disease to be the possible link. But again, I stand to be corrected. So please feel free to share your idea as well, as we are all learning together. All right. So over here, we are looking at this as a dysplastic type of obesity. All right. A 2.5-year-old child is ill for the second day. The onset of the disease was associated with temperature up to 37.8. A single bout of vomiting, watery diarrhea for 5 times a day. During the second day, vomiting occurred twice, temperature 38. Child has low appetite, watery diarrhea continuous. Guys, what treatment should you start first? The treatment of the child should start with So what are you going to do first? First of all, you have to control hydration, guys. This person will be dehydrated. The person will be dehydrated. So the first thing is to make sure that you are hydrating the person. So therefore, over here, we'll go in for what? For your ORS. ORS. That's oral rehydration solution. So here, your answer E will be the best answer before you start thinking of giving. Do a culture to know the bacteria that is causing it or whatever that is causing it before you now treat it. But first of all, you have to hydrate the person to make sure that this person will not enter into shock or, will not have a problem later on. So here, your answer is E.